Thank you very much for coming back for the second part of this lecture series. This afternoon we will focus on advanced prostate cancer. I'm going to be talking to you about biases of new imaging technologies in the advanced prostate cancer states. Here are my disclosures. So we talked this morning about categorizations using the advanced disease states model, but what in this model is advanced prostate cancer? Well, advanced prostate cancer is high-risk locally advanced disease, biochemical recurrence, metastatic disease, either hormone-sensitive or castration-resistant, whether it be oligometastatic or polymetastatic. Remember that these distinctions are usually based on bone scans and CT scans, and next-generation imaging, PSMA PET, whole-body MRI, etc., detects micrometastatic disease and microprogressive disease, which is not used in this classifier system. Now, all of us are aware that there are multiple challenges of using conventional imaging in advancing prostate cancer. So, for example, all of us know that there are clinical states where the PSA rises, but we don't see anything on conventional imaging. And this is usually due to microscopic nodal disease or bone deposits that are undetectable. So, for example, high-risk biochemical recurrence, where the PSA is rising, you don't see a thing. And we know that in non-metastatic castration-resistant prostate cancer, non-metastatic on conventional imaging, if you do PET scans, the vast majority of these patients, you'll find something on a PSMA PET, for example. So these are problems with conventional imaging. We also know that there are patients who seem to be getting worse. For example, the PSA is going up, but when we do their imaging, they look the same. Or they're progressing clinically and we do imaging and they look the same. What's going on there? So there are these difficulties in monitoring patients with bone disease due to limitations of current conventional imaging. So there's a great interest in identifying better imaging strategies to better inform on the optimal management of these advancing prostate cancer patients. And again, we need prognostic and we need predictive biomarkers. There's a great deal of interest in using modern imaging for this purpose. So we know that modern imaging is able to detect micrometastatic disease and microprogressive disease. And when you use modern imaging, you realize that the systems that we've been using are in fact imperfect. A lot of us will make claims like this. We claim that the earlier detection of metastatic disease will result in improved outcomes. Really? We claim that the detection of microprogressive disease enables us to change therapies in a more timely manner so patients will live longer. Really? These recent papers are really pushing back on us, saying that we really need better evidence before we make such claims. Now, in general, any imaging should better predict, better prognosticate, and enhance treatment decisions. I think all of us would agree. But so far, there have been incomplete management impacts of these next-generation technologies. In fact, we already see patients are being subjected to treatment intensifications that does not improve outcomes. And in fact, it seems to be increasing morbidity, mortality, and costs. On the other hand, we're also seeing treatments being withheld to spare unnecessary toxicities that may actually be leading to undertreatments. So we need better study designs that incorporate these next-generation imaging technologies, but we really need to now take the next step and show them management and survival impacts in advancing disease. So we know that diagnostic and prognostic markers improve lesion characterization, specificity, improves detection, sensitivity, but remember, it increases the detection of indolent disease as well as microscopic metastatic disease and microprogressive disease. Of course, we haven't talked about response assessment, but there's also an improvement there. But all of these come with biases. So what are these biases? We have stage migration bias and we have lead time bias, and we have length time bias that we need to discuss. The higher sensitivity of next generation imaging means that if you have a patient with what looks like non-metastatic locally advanced prostate cancer, they will in fact turn out to be oligometastatic. If you think they have oligometastatic disease, they have polymetastatic. So sensitivity is driving a higher stage of disease, whereas specificity is driving the disease in the opposite direction, because all the false positives are being reclassified also. And this can lead to something called the Will-Rogers effect, or a stage migration bias. So what is the Will-Rogers effect? Well, in conventional imaging, we can divide patients into metastatic and non-metastatic groups. And in the non-metastatic groups, you have patients who are truly non-metastatic. You have patients with metastatic disease who are misclassified, and you'll have patients with microscopic metastatic disease or indolent disease also being classified as being non-metastatic. And on the metastatic side, you'll have patients with true metastatic disease, and of course the false positives will also be there. And if you treat these men, these will be the survival curves for the metastatic side and for the non-metastatic patients. Okay, so when you use next generation imaging, what happens? Well, this patient who was false positive ends up here, and these patients here with microscopic metastatic disease and true metastatic disease will end up over here. So the prevalence of metastatic disease appears to increase. Okay. Now, when you treat them, in fact, what you find is that both groups' survival increases, because these patients here are truly non-metastatic, and so their survival improves. But you've got a dilution effect here, because these men with microscopic disease or indolent disease also end up in here, so you end up with a dilution effect. So in fact, their survival also improves. Furthermore, we have to remember that these patients' survival also improves because you are detecting microscopic metastatic disease at an earlier time point. In other words, the burden of disease is lower, and you're also overdiagnosing and you're also overtreating less aggressive tumors, which have also ended up in this subgroup. So this is called length and lead time bias. So length time bias is an overestimation of survival duration due to the greater detection and the overtreatment of indolent disease that's going to progress more slowly. Lead time bias is an overestimation of survival duration due to an earlier detection of microscopic metastatic disease. Let me expand that further. If you were to use conventional imaging to detect the presence of disease and you started treatment at a particular time point and they passed away here, this would be the overall survival. However, we know that next generation imaging is more sensitive. That means we detect disease at an earlier time point. If we use the same therapy and the patient lives just as long, then this apparent improvement in survival is just due to lead time bias. Lead time bias also comes in the setting of response assessments. So currently, when we use conventional imaging, we decide patients into progressive and non-progressive categories. But we now know that we can use next generation imaging to break this down. So we can now positively identify response, stable disease, and progression. And within the progression category, we can also identify micro-progressive disease. And this can also affect lead time bias. So for example, in conventional imaging, we diagnose the disease here, and there's the first treatment. That's when we diagnose relapse, and then we change treatment, and this is how long they lived. Okay. With next generation imaging, what happens is we detect micro-progressive disease at an earlier time point. If we use the same treatment and they live just as long, then this apparent improvement in the second treatment is in fact just lead time bias. On the other hand, if we detect micro-progressive disease at an earlier time point and we intervene appropriately on the microscope on the micro-progressive disease, then we use the treatment that we were going to use, then there's actually a possibility of lengthening overall life. So you can see how lead time bias is also acting in the response assessment paradigm. So just to conclude, next generation imaging introduces biases because of the earlier detection and treatment of both important and unimportant disease. Stage migration bias is improved survivals due to reclassification of microscopic metastatic disease and indolent disease into higher disease states. Lead time bias is overestimations of survival duration due to the earlier detection and the earlier treatment at staging micrometastatic disease or during response assessment micro-progressive disease. And length time bias is due to the overestimation of survival duration because you're overdiagnosing and you're overtreating indolent cancers. And I'd like you to bear these thoughts in mind as we look at advancing prostate cancer. Thank you very much for listening.